Welcome everybody. My name is Lisa Cronk and I am the nurse at the ALS Association, and we're delighted that you are all here today. This is just an overview of our talk, or at least my portion. That'll be for the first hour here. What Jennifer had asked is if you hold questions until the end of my portion, and then we'll save some time so that if you had questions about anything that I've said today, if you could ask them at that time, it would be greatly appreciated. Okay, so let's get started because we have a lot to cover. In the United States, ALS is more commonly referred to as Lou Gehrig's disease. Lou Gehrig was a famous New York Yankee baseball player who actually was diagnosed with ALS at the Mayo Clinic in Rochester, Minnesota. He died 2 years after his diagnosis. In other parts of the world, ALS is more commonly referred to as motor neuron disease. ALS was first described in the scientific literature in the late 1860s, and that's the first of many frustrations that patients and families will have. They say, you mean you've known about this disease for 100 or 140 years, 150 years, and you still don't know what causes it, and you don't know how to cure it, and that is true. What helps me, if we take ALS, the acronym, the words are amyotrophic lateral sclerosis. And I think the best way to understand it, if you break each word down, A in the amyotrophic refers to without, myo refers to muscle, and trophic refers to nourishment. So without muscle nourishment. And I'm not talking about the calories people take in, but it's message that goes from the brain to the muscle, and I'll talk a little bit more about that. Lateral just refers to the sides of the spinal cord where the motor neurons are located, and sclerosis is the hardening or scarring when those motor neurons die. ALS affects motor neurons in the body, and motor neurons are just nerve cells. They carry messages from the brain to the muscle, and basically they tell the muscle what to do. Involuntary muscles, and they affect the voluntary muscles. Involuntary muscles, like the heart muscle, is usually not affected by ALS. ALS affects both upper motor neurons and lower motor neurons. And upper motor neurons are in the brain, and when they're affected, you might see symptoms of weakness and spasticity and really brisk type of reflexes. The lower motor neurons are located in the base of the brain, and they make their way out through the spinal cord. When those are affected, you see weak muscles, but they also atrophy or waste away, and they get smaller. You might also see some muscle cramping as well. This is kind of if you visualize a horizontal detailed slice of someone's spinal cord, this shows you that if you kind of visualize that, on the left-hand side, if you look at these as healthy motor neurons, you're going to see a healthy muscle tissue. And then on the right-hand side, you're going to see motor neurons that are affected by ALS, and then the muscle will get smaller, weaker, or atrophy on the right-hand side. When the motor neurons die, they can't carry out their normal function, and they get smaller. They become increasingly impaired. And this, again, just simply shows a healthy muscle tissue on the left and affected muscle tissue on the right. Eventually, most people, if they live long enough with ALS, will become paralyzed because of this weakened or smaller muscle. In the United States, we're pretty confident to say that there are 30,000 people living at any given time with the disease. So there's probably 5,600 new cases every year in the United States being diagnosed. The age is going to vary. The mean age is 55 or 56, but most of the people at the ALS Association have actually worked with people in their late teens and as well as into their low 80s that have been diagnosed with the disease. And there's slightly more men than women that get ALS. In Minnesota, we're very confident, unfortunately, to say that there are 2 Minnesotans who are diagnosed every week with the disease, and that same number probably die of the disease. And in North Dakota, probably 1 person is diagnosed every month and 1 person dies every month. So at least in Minnesota, we know there's at any given time somewhere between 300 and 400 people living with ALS. What it means is that 300,000 of us who are alive and well today will die of the disease unless we can find a way to slow the progression or to cure the disease. Other things that we know about ALS is that it's not contagious. So working closely with somebody with ALS, working with their body fluids, breathing their air, you cannot catch the disease from being close to somebody with ALS. We also know that it's in the neurodegenerative family of diseases, so similar to Parkinson's and Alzheimer's, it's in that same family of diseases, yet it probably has the highest disability. We also know it's a progressive wasting away of skeletal muscle. Depending on where the symptoms first start is what we would call either limb onset, bulbar onset, and respiratory onset. Limb onset, probably the most common, and that's when a person would experience symptoms in their limbs, their arms, their legs, for example. So we have people who start tripping over nothing because they have foot drop and their ankle muscles have weakened and they start to trip. We've had people tell us they can't grip their golf club as easily or as the same way as they once did. That might be their first symptom, and we would refer to that as limb onset. If the muscles in the face and the throat are first impacted, then we refer to that as bulbar onset. Bulbar onset is, bulb is the brain, and the brain looks kind of like a garlic bulb, so that's where they come up with bulbar onset. And so a person's first symptom could be slurred speech, as an example, or possibly they have a difficulty chewing or swallowing. So those could be the first symptoms. There's a very rare type of onset. It's called respiratory onset, and a person doesn't even know they have ALS, but they have some kind of acute respiratory event that brings them to the emergency room, and they, again, don't know they have ALS, and either they die because it's such an acute event, or they get stabilized, and after they're stabilized, their physicians figure out their breathing problem is a direct result of ALS. So very rare, but it does happen. Things that ALS does not affect, or at least that we know it doesn't affect, it seems to spare the sensory nervous system, so people can see, they can hear, they can feel touch, those sorts of things. Recent studies have shown that maybe up to 30% of the people with ALS might have some problems with their thinking, their cognition. We never used to believe that. It's a fairly new understanding in the last 5 or 8 years for us. We didn't think it affected the way they thought, but now we do believe at least upwards of 30% of them will have that difficulty. Maybe even 50% of the people will have behavior changes, but we understand that that is to me at least, it's more understandable that they would have some difficulty in their behavior or a different behavior that their family reports. But it is important to remember that sometimes people who are completely paralyzed by their ALS will have an intact cognitive functioning. Because ALS presents itself differently in everybody, diagnosis can be a bit of a challenge. It can be difficult, and sometimes it's misdiagnosed. It's diagnosed through a process of elimination. So a physician basically has to do all kinds of tests, whether it be spinal taps, muscle biopsies, blood work, etc. They're looking for other causes of the symptoms. So they're trying to find out if there's something other than ALS causing this problem. When they've ruled out everything else and they've done an EMG or the electromyography test, and if on the electromyography test they see signs of upper motor neuron damage and lower motor neuron damage, then a physician can say they definitely have ALS. So oftentimes if we're at clinic, we'll see in a person's chart that they possibly have ALS or probably have ALS or before it's a definitive diagnosis. And sometimes that process can be 6 months, 12 months, 2 years before they finally figure out what indeed is the cause of the symptoms. People often ask us if there are different types of ALS, and that's a hard yes or no answer or question to answer. The majority of cases are what we refer to as sporadic, so it's the most common, 90 to 95% of the cases. It can start in the limbs, it can be a bulbar onset ALS. The only issue is that there is absolutely no other family member who's had the disease. So again, most common and no family members. There are 5 to 10% of the cases that what we refer to as familial. Clinically, it looks no different than the sporadic form of the disease. It can be limb onset, it can be bulbar onset, but the sole distinguishing factor is that there is family history of the disease. And most of us at the chapter have worked with people who, when it's in the family, it's really in the family. Like we worked with somebody in Coon Rapids. She was the fourth of 5 adult daughters to die of the disease. So usually we can quell the nerves of people that odds are in your favor. If you don't have any family history, you have the sporadic form. But this is where genetic counselors actually come in handy to try to help determine if this is the familial form of the disease. Very briefly, there is what is now called environmental ALS. Years ago, it was called Guamanian ALS, and essentially what it means is that people would not only have ALS, but they'd have Parkinson's and they'd have some form of dementia. So they would have all 3 of those neurodegenerative diseases. We call it environmental because there's some belief that something in the environment caused those 3 things to happen simultaneously. Very rare. I think in my 14 or 15 years with the chapter, I have seen it maybe 2 or 3 times here, max. So it's very, very rare. And again, we talked briefly about the cognition, the issue with that. It seems to affect the frontal temporal lobe in people's brains when they have cognitive impairment with their ALS. As I mentioned, the disease presents itself differently in everybody, so care and treatment is going to vary from person to person. So many of you in this room have worked with people with ALS, but I bet if you've worked with a number of people with ALS, they could look very, very different. And that's one thing that we really want to point out, that not everybody is going to progress the same way. We do know, however, that it's progressive in nature. It's just the rate of progression that is variable in this disease. There's a lot of non-ALS informed healthcare providers that will tell a newly diagnosed person to go home, get their affairs in order. There's nothing that can be done. And we really disagree with that. We know we can't cure this disease, but we think there is a lot that can be done to treat symptoms, to enhance the quality of life, and maybe even prolong life. So again, there will be a talk later on about the importance of attending a multidisciplinary ALS clinic to help with quality of life. We've had a lot of people who have sought unorthodox treatment modalities, and although we appreciate that they need to do whatever they need to do, our worry is that some of these treatments we hear about have been not proven. They certainly can be unsafe, but our biggest worry is that it depletes a lot of their finances, and this can be a costly disease with having to get care at the end of life, use equipment, that sort of thing. So that's our biggest worry. This is a list of symptoms that people with ALS might have, and just as I said a few minutes ago, it's important to remember that not everybody you see will have all these symptoms, but we thought it was important to let you know that these are symptoms that would not be atypical in ALS, that we might expect to see them. The other thing I want you to be aware of is that we also believe that by the time a very first symptom starts, whether it's that I can't grip my golf club, or I'm starting to trip over nothing, or I'm slurring my speech, by the time that first symptom appears, we think that upwards of 60 to 80% of their motor neurons or nerve cells have already been destroyed in ALS. It's kind of amazing that our bodies can, the other motor neurons, the healthy ones in the body, can compensate for these dying motor neurons, but eventually they can't sustain all of their work and the work of these dying or destroyed motor neurons, and so that's when we first see a first symptom. But imagine being diagnosed and being told that probably by the time we're seeing you, 60 to 80% of your motor neurons are already destroyed. So taking that list and kind of starting from the head and working our way down, again, bulbar just refers to the brain stem or the bulb. And symptoms could be dysphagia, which is just difficulty swallowing, or it could be dysarthria, difficulty speaking. So those are 2 symptoms that involve the bulb or the brain stem. People that have the difficulty swallowing, it might look like their body's producing a lot of saliva that saliva's running out of their mouth. It's a symptom that they can choke on that saliva. It's something they could aspirate into their lungs, and it's frankly an embarrassing symptom. So there are medications that can be tried to dry up those secretions. There are portable oral suction machines that a lot of people use. And if we're not able to control the saliva that way, people have actually had Botox injected into their salivary glands with the hopes that that would control the secretion. So it's a tough symptom, but usually we're able to control that. Sometimes people have the polar opposite. They'll have really thick, tenacious secretions in the back of their throat. Maybe they mouth breathe at night, or maybe they're just very dehydrated. So there are things that we can do to try to increase their hydration. There's medications that can help break up that thick phlegm in the back of their throat. So again, there are things we can do to at least try to make those symptoms go away. This is where dietitians and speech-language pathologists are vital in the care of ALS. They can give ideas when your swallowing first becomes a problem, maybe changing the consistency of the food, having 6 small meals a day instead of our traditional more 3 bigger meals. But there's a lot that can be done. This is a point where we want people to take in a lot of calories. We don't want them to lose weight because we know they're going to be losing muscle already as the muscle wastes away. So it's kind of one time in our life where we're telling them to actually increase the calories to try to stay or keep your weight on. Eventually, people with ALS have to come to a decision, most of them, whether or not they want a feeding tube. And personally, I think it is one of the most kind things they can do for themselves and for their family members. And just so you know, sometimes when they're trying to eat and they're choking and they're coughing and they're sputtering, they're expending more calories than they ever get into their mouth. And so, again, they're going to lose weight because they're not getting in enough calories. Sometimes when their breathing's affected, you can burn an entire day's worth of calories just by the act of breathing when your breathing is compromised. So again, dietitians, speech-language pathologists all can help with that. But feeding tubes are a good thing, and they're good to have in early so that a person could use them, stay hydrated, take their pills, and supplement their nutrition as needed. The dysarthria, the difficulty speaking, again, could be slurred speech. It could be they can't project their voice loud enough. And there are some devices that my colleagues here will talk about a little bit later in our talk about those types of devices and the technology available. Truncal muscles, that's the neck muscles, they can get weak. And our head weighs a lot. Our head weighs like a bowling ball. And if you have weak neck muscles, it's really hard to be able to keep your head upright. And so they use neck braces or cervical collars to try to keep the head upright. You certainly, if somebody's still ambulatory, they're still walking, they're going to be safer if they can see where they're going versus having the head of their head down. You're going to eat better or swallow better when your head is upright, and you're also going to breathe better when your head is upright. So it's really important to use cervical collars when necessary. Fasciculations, that's just the twitching motion that people with ALS might have under their skin, on their tongue. It's just the muscle with a little rapid twitching. Usually doesn't require treatment, usually isn't a problem, but it's a really distinct symptom in ALS. Psychologically, people with ALS can be emotionally labile. We've had people who they talk about almost a roller coaster where they start to cry at something sad, but then they really cannot control their crying. Or we had one lady who would go to funerals and she would start to laugh, and something funny might have been said in a eulogy, but she would inappropriately laugh. So she doesn't go to funerals anymore. And we don't quite understand what's happening there, but people with ALS can be emotionally labile. Usually they tell us that they aren't feeling quite as sad as they might look, or they're not thinking something's just funny, but they just can't stop from laughing. So there are some medications that can be used, but again, not often something that gets treated. The cognitive issues that I talked about, again, with the frontal temporal lobe, what we see is probably poor insight, lack of judgment, maybe a wife or a spouse will say, he would have never made that kind of decision. He would have never said anything like that. So that's the kinds of things we see. They might have some poor planning, some disinhibition, things like that, the things that you would expect to see if the front part of the temporal lobe is impacted. We think that survival is probably shortened if they do have this cognitive impairment, and most likely it's because they can't make decisions that you and I would make. If we sit and tell them it'd be really important to put a feeding tube in now so that you can have hydration and nutrition, they'll go, I don't need it, even though maybe they're getting in 400 calories a day at the most and are exhausted at the end of the day just from the act of eating, but they can't think as clearly as you and I might think. So we think it does shorten their survival if this is an issue for them. Their mood and behavior, again, changes. Certainly they can have denial and anger, and Jennifer is going to talk a little bit more about that in her session. The breathing part. Breathing is an involuntary process, and so you say, well, Lisa, you said it affects the voluntary muscles. Well, the biggest muscle in our body, the diaphragm, does about 70% of our breathing work, and that gets weak just like muscles in the leg, muscles in your mouth. It gets weak, and when that happens, all your other muscles have to start doing that job too, and eventually you aren't able to breathe in enough oxygen or blow out enough carbon dioxide. You need to be well nourished to breathe efficiently, so another plus for the feeding tube, or at least keeping your calories up. People start to notice this problem if it's not, they're in that rare amount where they have respiratory onset as their first symptom, but they'll start to notice it that, I used to be able to walk across our house and I was fine, and now I have to sit down in the living room because I'm so short of breath. So when they start to move and do things, they'll notice it. Or we'll hear from people that, I used to sleep just with one pillow at night, but now the spouse is reporting that they're either sleeping on 2 or 3 pillows, or they're sleeping in their reclining chair all night. And it's because when you lay flat, your intestines and your stomach, that all presses up against that weakened diaphragm, and it makes that weakened diaphragm work harder. So they just realize that gravity helps, and if they're sitting more upright, they're going to breathe more efficiently. So we start talking about hospital beds, bed wedges, that sort of thing. And years ago, when people's breathing got so bad, they really had 2 options. They had the option of doing nothing, be kept comfortable, and then they would die. Or they could make a really drastic decision and decide to have a tracheostomy tube and have invasive ventilation, so they'd have a ventilator hooked to them. And not many people make that decision, but some do. But those were the 2 choices. And about 20 years ago, they took a device called a CPAP. Probably most of you are more familiar with that. People who have sleep apnea use a CPAP device. They took that device and they modified it, and they made it into what's called a BiPAP, which is just simply bilevel positive airway pressure. And the bilevel kind of does the job of that weakening diaphragm. It helps, it's not attached to oxygen usually, it's just 2 pressures, and it forces people to take a big deep breath in, and then another pressure forces them to blow out the carbon dioxide. And that's what we think not only has prolonged life by people using a device like this, because it does rest their respiratory muscles, but it enhances the quality of life, because we all know what it's like to be sleep deprived. Well, imagine if you're not getting in enough rest because you're not breathing well at night. So people's quality of life it can really be enhanced if they use a device like a BiPAP as well. And then eventually the BiPAP is not enough to sustain life, and you're back to those 2 decisions of either having invasive tracheostomy and ventilation, or just being kept comfortable and dying at that point. Respiratory therapists, lung specialists, the pulmonologists are all vital in the care of an ALS patient, and it is respiratory failure that most people with ALS will die from. This is a woman who's wearing her BiPAP mask, so you get an idea. That mask can look like a CPAP mask too, where it just goes over the nose or mouth, and it also could be just nasal pillows too. So most people wear their BiPAP if they need it, at nighttime, but we find more and more people with ALS will use it in the daytime too, if they're taking a nap, if they just need to get a little more energy, that sort of thing. Now we've sort of made our way down, and we're going to talk about that muscle wasting away or atrophy. Again, without that impulse coming from the brain to the muscle, all the muscle does is sit there and it becomes flaccid, it wastes away, it gets smaller. People with ALS can have muscle spasticity, and sometimes that's actually helpful because you can help pivot transfer them better, but it can be uncomfortable, and they have horrible muscle cramping at times. So we've all had terrible Charlie horses in the middle of the night in our calf, and we jump out of bed and we're trying to get rid of that Charlie horse. Imagine those cramps all over your body in ALS. So people with ALS can have that kind of discomfort. And there are medications that work on spasticity and muscle cramping, but actually what we found even more helpful was doing range of motion every day and stretching exercises every day. That seems to help prevent some of that cramping and spasticity. So if you're working with a client who has ALS and they don't have range of motion incorporated into their daily cares, that might be something to talk to them about, because it is really, really important for them. Physical therapists are the people who can really train a person how to appropriately do range of motion and stretching exercises, and they're also experts when it comes to equipment, so they can tell you what might help to keep a person safe, independent, those kinds of things. So we really rely on physical therapists for that. And occupational therapists, the same kind of thing. They become bathroom equipment experts, and they can really give patients, especially in the early stage of their disease, assistance in different devices that they could try. Because I think as most people, we want to be as independent as we once were, and so there are some amazing devices out there that will help them, and we'll talk about that later today in this talk. And there's some amazing technology out there as well. Other symptoms that we could see, pressure ulcers or bed sores.